I'll have to do the checklist.
Yeah.
Hi guys, this is Charles. I'm one of the surgeons at Southpaws. Today we are taking out a left adrenal gland tumor in a little dog that presented for an ear mass, and the owners noted that incidentally it had been polyuric polydipsic and that the vet had picked up an adrenal gland tumor. We're going to quickly do our preoperative checklist. So confirming that the ground plate for the cautery is connected, confirm slide and procedure, so that's the left adrenalectomy. We've already confirmed all our instruments that we're going to need. We don't need any photos. Potential complications would be blood loss during surgery, but it shouldn't be a big deal. And we are going to treat with solumedrol at the time that the adrenal gland's coming out. Risk of blood loss is moderate. Okay, if you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so that you'll get a ding on your phone the next time we live stream. So we're making our midline incision here. And I'm standing on the left side of the dog, which is unusual for me when I'm doing a abdominal exploratory. Normally I'm on the right side, but because it's a left adrenalectomy, it'll be a bit easier for me to stand over here. Where's the linea here? So coming up to the xiphoid. So that's linea alba right there. I've lost it a little bit caudally here. Let's see if I can find it with my Metzen bones. All right. And we're going to go all the way up to the xiphoid with our incision, and then we'll make sure that we take out our falciform fat. It's funny how disorienting it is to be coming in from the opposite direction. We've done a CT scan, which didn't show any other abnormalities in the abdomen except for moderate hepatomegaly. Chubby little dog. Bit of liposuction. There's some way for me to get this done on myself. All right, so there's that liver, and the liver looks pretty typical for steroid hepatopathy, kind of slightly lighter beige in color, and there's a bit of a nutmeggy appearance to it, and the edges are all rounded, so that's fairly typical. These balfours are quite large for this procedure. We had 2 septic abdomens this weekend, and so our other balfours, the appropriately sized ones, are being sterilized. Extend the incision caudally a little bit more. All right. And then we'll just put in our spoon as a centralizer. Is that okay?
Yeah, spleen out from underneath.
Yep. Thank you. So that's what the spoon does, is it just centralizes the balfour. Keeps it from drifting to one side or the other. All right, so now big gallbladder, but it's soft. I'll just express that. So that's expressing easily. Have a look at the liver and see if there are any discrete masses. The fact that we've done the CT scan means that it's less likely that we will see anything that we're not expecting on the XLAP, but And I know some surgeons that don't even bother with doing a complete exploratory when they've done a CT scan, but I think it's still a good idea. So the stomach feels okay, and I didn't see anything on the scan. So there's duodenum there, and we'll come and have a look at the opposite adrenal gland, which is going to be hard to see because it's the right side, and I can feel it, but I can't see it. So urinary bladder there, coming around to the caudal duodenal flexure. Just pull the guts up here. Getting into jejunum. And there's the antimesenteric vessel there that tells us that we're in the ileum. And there's the cecum, colon. We'll pull the guts over to the other side. Get the spleen out.
There's a question about if the weight of the patient negatively affects the surgeries.
So really fat dogs, it's a lot harder to see what you need to see. All right, Jeff, let's get your hand, one hand right there. Yep, way deep down in the hole. Okay, and so we can see the adrenal gland right there, and we'll just get a laparotomy sponge to protect and keep the intestines moist. Okay, and just get that kidney out of the way. Now, how does it look there? So that's the adrenal gland there. Let me just see if I can pull the camera back. So can you see the adrenal gland there? Yep. All right, so that's the adrenal gland sitting right there. And get this little hook. I had this little hook made for my cautery, which is really nice to be able to hook onto the retroperitoneal fat and just kind of tear that as I go. Can I get the cautery turned down to 20, please? All right. Good? Let's see if I can zoom in a little bit as well.
There's a question about asking if the kidneys are in the retroperitoneal space in dogs and cats.
The kidneys are retroperitoneal in dogs and cats. Same as in humans, I think. There's a little bit of fat leaking out there. So then I just hook around and make a window in the retroperitoneum all the way around. And the next thing that we're going to do is ligate the frontoabdominal vein, medial and lateral to the adrenal gland. Get that liver out of the way a little bit. All right, and then I'm just going to come medial to the adrenal gland with my ligature and ligate the frontoabdominal vein Can I ask for a new ligature, please? We'll chuck this one in the bin, please. The spring has gone on it. Thank you. Okay. Have we given the Soyomedrol?
No.
Let's go ahead and give that now.
Give it now?
Yep. I can see the left renal vein, just caudal, right there. You can see it just medial to my ligature.
Question about whether this can be done from it says posterior approach, but I imagine maybe they mean more for the paravertebral.
Yeah, we can do a paracostal approach, which is really nice. It's you can't do a complete abdominal exploratory that way, but you can certainly get the tumor out. Okay, so that's the tumor out there, all in one piece. Capsule's intact. Got a little bit of a bleeder. Not much. Thanks. All right, that looks pretty good. Make sure that my kidney is okay. Just find my renal vein. Make sure that no, that's right there. So that's intact. I haven't ligated that.
So a little bit of bleeding just from the edge of the renal vein from this of it.
Let's see here. Just try to pull things out of the way so that I don't contact there. Can I get hemoclips, please?
Here's some hemoclips. We'll need the applicator as well.
Yep.
Got a little bit of a bleeder coming out from the side of the renal vein, and I don't want to zap it with the ligature because I don't want to damage the renal vein. Honestly, if I just pack this off for 5 minutes, everything would stop bleeding. Thank you. And just try to retract that kidney caudally for me, please. Okay. All right, that all looks pretty good now. All right, so sorry about that, just hit my head. So now, can you just push that button right there just to zoom out? Yep. All right, so we will now just take a liver biopsy. We'll get everything back inside the abdomen. Just lift up on that spoon for me, please. And I'm just going to shave a little bit of liver off the side here. And then just blot that for me, please, if you could. We'll get the cautery turned back up to 40, please. Just hold off some pressure on that until we get the cautery turned up. Question about what an adrenalectomy is. So that means we're taking out the adrenal gland. The reason why we're removing the adrenal gland is because it has a tumor in it, probably a benign adenoma, but it's producing excessive cortisol. The excessive cortisol is what's causing the liver to look like it does. So you have what's called steroid hepatopathy, which means that you have excessive circulating cortisol that's causing changes in the liver. Let's go ahead and lift that out here. Get our if we've got some towel clamps, that would be great.
Oh, yes, it is.
Just get a couple of those. And do we have a pool tip? Let's get some warm saline, please. Is there saline warm already, or? We don't need a lot of flush. It is not a partial adrenalectomy. We're doing a complete left adrenalectomy. And hello from Argentina. Regarding ureteronephrectomies, I've probably done a dozen of them, usually for cancer. Hello, Piyush or Piyush. And question about, have any other doctors at Southpaws agreed to live stream? And the answer to that is no. I'm trying. I'm working on it. You want to grab that suction? Can I get some O-proline, please? And I'm closing the abdominal wall with a non-absorbable suture. Because this dog has Cushing's disease, it's going to have slow wound healing or delayed wound healing. And so we're going to put in some suture that's going to last a little bit longer. So how many people are in the operating room for surgeries in general? Usually between 3 and 4 total. It'll be myself or the main surgeon, an assistant surgeon, and then a nurse anesthetist. And then possibly, like usually at the beginning of the surgery, we'll have a circulating nurse who's opening instruments and stuff, and then they'll leave when the surgery is can you rotate that around, please, so that so just turn it. Yep. Keep going. Yep. That's great. Thanks.
Pretty centered.
Yeah. And then regarding the cortisol levels, so now the cortisol levels, just rotate it a bit more, please. The cortisol levels are going to drop precipitously because we've taken out the source, and the other adrenal gland is not able to produce cortisol because it's had feedback inhibition. So we give a single dose of solumadrol at the time of surgery, and then as soon as we can, we started on oral prednisolone, which has mineralocorticoid activity, and we also start them on fludrocortisone, which has a lot of mineralocorticoid activity. And we discontinued the fludrocortisone acutely in a month, and then taper the prednisolone over about 2 months. And I don't normally monitor electrolytes and adrenal function after this. This is a protocol that I've done on several hundred patients, and I'm happy with the results that we get. And I have not had an Addisonian crisis develop to my knowledge in one of my patients. So that's the way I like to do it. I know that some people have a more directed approach where they don't administer supplemental cortisol, and then they check for Addison's disease and check electrolytes overnight and stuff like that. And it seems like a lot of unnecessary activity. If you just go ahead and supplement them, you know they're going to be low. Go ahead and supplement them, and then taper them in a time frame that you're confident that the other adrenal gland is going to be able to take over. That is my approach on these. And again, I'd be happy to discuss that approach if anybody has any better or other ideas, but I'm pretty happy with how they go. I don't put these on any heparin or other anticoagulants. It's interesting that with proline has much less tissue drag than PDS. So with proline, you can take there are probably 3 or 4 bites like this and just pull it through. Compared to PDS, if you try to do more than a couple of bites, it's going to get bound up in the tissue.
Here's another question that says, is the warm saline used for sterilization?
The warm saline is used mostly, honestly, to warm the patient up. Also, we're looking for hemorrhage in that if we go to suction the saline out and it's completely, basically half and half with blood or something like that, it'll look very red, and then that'll tell us that we need to go back in and have another look. And then the other thing is that we're lavaging out the abdomen of potential infectious agents that might have been introduced during the surgery. And that's controversial as to whether that actually prevents peritonitis or adhesions or anything like that. So I don't feel strongly one way or another about lavaging after surgery unless you've got gross contamination.
Someone's response to just medicating the animals after these sorts of surgeries, regardless, is that's right. You're a surgeon, not a medicine guy. People around.
Yeah. If it ain't broke, don't fix it. Actually, that's not the surgeon's motto. The surgeon's motto is fix it whether it needs it or not.
Any excuse to cut.
Yeah. Can I get, please, some 3.0 PDS? Actually, I might have you take over here. Now, I've got a little mass that this is why the dog actually presented in the first place, is a mass next to the ear. So I'm going to steal this light with the camera on it, move it up to here. Do you have enough light?
Yeah.
All right, so we'll zoom in. Great. All right, so this is our mass sitting up here, just over the parotid salivary gland. So we're back to our normal suction tip. So, and it's a subcutaneous mass over the parotid gland, kind of sitting on top of the ear canal. Aspirate revealed sarcoma or spindle cells. So presumption is soft tissue sarcoma, although a salivary gland tumor is possible as well. That skin is so loose in this area. Grab my Gelpi retractors here. Because we're getting a 2-for-1. Satisfaction guaranteed or your money back. So this should be platysma muscle here. And we're probably going to see the maxillary vein in here somewhere. That might be it right in there. No, that's a muscle. If you're going to use Gelpi retractors, keep repositioning them so you get the maximum benefit. So this is just right ventral to the external ear canal, sitting right on top of the vertical ear canal.
There's a question that says if you make the J-hook cautery pencil, or is it something commercial?
The J-hook cautery pencil is something I had made. I had used one before, and we haven't been able to find it again. And so the company finally just, rather than continuing to look, just made them custom made for me. So that's parotid salivary gland right there that we're cutting through, and that will not cause any problem because we do this routinely with total ear canal ablations. As in cut into the parotid salivary gland. Hopefully my head's not in the way. Is it all right, Jeff?
You were able to waking up a little bit earlier.
Yeah, I just did.
Okay, so that's the mass out there. Can I get some 3.0 PDS, please? Thank you. So the laparoscopic hooks for cholecystectomies, we definitely have those. And regarding ligature, yeah, it'll change the way you do surgery. Somebody just said that I've convinced them to get a ligature. And ligature is amazing. Like if my ligature was broken and I had an adrenalectomy, I'd probably try to reschedule it for when my ligature was fixed. And getting a refurbished unit or secondhand unit is fine. We haven't had any maintenance issues with any of our units. We've gotten them all as either demonstrators or secondhand. So we have 3 ligatures now. And if you get the force triad, you can use it as a regular conventional electric cautery as well. Just a little bit touchy as far as the ground plates are concerned. Covidian, or whatever the company is, Covidian has made it very sensitive to the impedance in the ground plate so that you have to buy their disposable ground plates. And so that's their revenue stream. It's cautery tips and ground plates. I'm trying to close some dead space here, and I would definitely not drain this. I know a lot of people would, but you guys that watch our videos often would know that we should be reducing the number of drains we put in, and certainly not a Penrose drain. Blasphemy, that's right. So, Stefania, do you want to do post-op meds now?
Just 1 second.
Yeah. So, pain relief. Oh, sorry.
No, no, go ahead.
Stefania's in the middle of.
Pain relief?
Yep. So, just methadone.
Yep.
And then or a fentanyl patch, and shave a new spot for it. And then no,
For the leg?
yeah,
Okay.
and then no non-steroidals. We're going to put it on pred, 0.5 milligram per kilogram twice a day for a month, and then taper.
For a month, you said?
Yep, and then taper. And then fludrocortisone, and I don't know the dose of that. We'll have to look that one up.
10 to 15 micrograms per kilogram, twice daily for 2 weeks.
10 to 15 micrograms per kilogram, 10 to 15 micrograms per kilogram twice a day for 2 weeks. Is that what you said? Good thing Jeff's here.
Okay. Antibiotics?
No antibiotics.
Sedation?
Yeah, just a little bit of ACE.
Rechecks?
1 and 2 weeks. And if there are any concerns overnight, they should run electrolytes.
Question if there's any more live streams predicted today.
I have another surgery today. I can't remember what it is. Oh, possible inguinal hernia. And so if I do take that one to surgery, I'll try to live stream it. It's either an inguinal hernia or an inguinal lipoma. And so we're going to CT it to see which one it is.
need to?
Should be okay. Yeah, we've got a couple of extra pairs.
Any?
We don't need any. Yeah, we're all good.
Question about if Jeff is an intern.
Jeff is a resident. Jeff is a first-year surgical resident. He did his internship. Well, he was in practice for a couple of years, and then joined us for his internship 2 years ago. And then we couldn't get rid of him, so we kept him as a surgical intern for another year, and then we still couldn't get rid of him, and so we've given him a surgical residency with the hope that he will eventually be a Southpaw staff surgeon. And I'm sure that he will be happy to live stream. Somebody has to carry the torch, the live streaming torch.
That's a few years off now.
Yeah.
I want to say I've probably been in the most live streams with you.
Yeah. That's probably fair enough. Can we get some 3O monosin, please? Thank you. I might just leave this open for you, Jeff. All right, so that's it for me. I'm just going to come over and make sure we've answered all the questions. You don't plan on retiring on us, do you, Doc? I will retire one day. I don't know when, so what did we pre-med with? We pre-medded with ACE and methadone, is that correct? Yeah, ACE, promazine, and methadone. No glycopyrrolate or atropine unless you need it. And do they refurbish end seals too? I think they do. Let's see, ballpark cost on a ligature. We're paying about 4,000 to 5,000 Australian, which is about probably 3,000 US. I'm not sure if they're available. I would look on eBay. Often they do come up, or talk to your local medical equipment supplier. Let's see. Any other questions? Had an instrument that liked for me to wet his hands while tying proline suture, said it helped stop sticking from the hands. Yeah, that's really handy. Like if I'm doing a lot of hand ties and cardiac and stuff like that, then wetting the hands is really helpful. Why ACE and not dexdomitor? We're just really happy with ACE. Just a very, very low dose, 0.05 milligrams per kilogram is what we're using. 0.01 milligrams per kilogram. So it's just such a low dose. And even at that little bit, it really smooths out the anesthetic. So if we need a higher level of sedation, that's when we'll think about using the dexdomitor. So anyway, well, that's it for me. Thank you very much for watching. Make sure you have subscribed to our channel and turn on notifications so that you'll know the next time we're going to live stream. Again, thanks a lot. Hope everybody's safe and well, and we will see you again soon, hopefully later on today.